Hello, welcome to the lecture course at the Department of Propedeutic of Internal Medicine number 2. I am VictoriaKhomazjuk, Associate Professor, and our today's lecture is devoted to the chief signs and syndromes in nephrology, and we will speak about glomerular nephritis, pyelonephritis, and chronic kidney disease. Before we will speak how to make a diagnosis of the diseases of the kidneys, you should remind the main data from anatomy and physiology about urinary system. So please look through these main characters of the system. And you should understand that it consists of two kidneys, ureters, and bladder. Then we begin our examination of a patient with problems in urinary systems from interviewing, of course. And here you can see the symptoms which may be present in a patient with urinary disease. First of all, we speak about flank pain. Then we ask about burning or pain with urination, urinary frequency or volume changes, urinating at night or nocturia, blood in the urine or hematuria, changes in the urine's color, clarity, and odor, urinary incontinence, and about edema. You remember that nephrotic edema usually appears on the face after sleep. Oh, well, our next step will be asking about some problems from the past medical history. They may be abdominal or urinary. They may be abdominal or urinary tract surgery in the past. It may be also urinary tract infections, major illnesses, blood transfusions, exposure to parasitic infections, exposure to tuberculosis, different medications. All this can influence the development of the urinary disease. We also should be interested in family history of our patient. We will ask about kidney diseases, hypertension, renal calculi, and hydronephrosis in the family. Also, some information from personal and social history may be very important for our diagnosis. These specific features of nutrition, some stressful life events, exposure to infectious diseases, travel history, trauma, and use of alcohol and drugs are very important to find out risk factors of the diseases of the urinary system. Our next step after taking history will be physical examination. Of course, we begin from inspection and we pay attention to the color of skin and the presence of edema. Then we auscultate for vascular sounds over the abdomen. Do you remember that auscultation will be on the second place when we inspect the abdomen? Then we percuss and we check for Pasternatsky sign. And we also palpate the abdomen to assess pain and to evaluate kidneys. First of all, I'd like to remind you that edema in the diseases of the kidneys appears on the face of the patient, usually after night's sleep. And the skin over this edema may be warm. Then accumulation of fluid may appear also in the abdominal cavity. It is called ascites, and also edema may be found on the legs of the patient, so-called pitting edema, and the edema of the entire body or anasarca may be present. This picture will remind you the sites for auscultation for bruise. If the murmur is heard over the artery, it is called bruit. And we see two sides for auscultating bruise over the right and left renal arteries in case of their stenosis. Next step in physical examination will be palpation of the abdomen, and we use it to detect tenderness in some areas, muscular resistance, some additional masses, fluid in the abdominal cavity, and evaluate size, shape, mobility, consistency of the kidneys. Here are the areas of cutaneous hypersensitivity in different diseases, and we see that in case of affection of the kidney, we may find tenderness or hypersensitivity in this zone and over the projection of the ureters on the site of affection. Then we may check for so-called Pasternatsky sign. The patient may feel pain when you percuss in the lumbar region, like this or like this. And in this case, the Pasternatsky sign is considered positive. We also can use deep methodical sliding palpation of the kidneys. In this slide, we can see palpation of the right kidney. We use both hands. The left hand will fix the costal arch and ribs, and the right hand will palpate. Don't forget to use breathing during your palpation. You should go deeper during expiration of the patient. And during inspiration, you will try to palpate the lower pole of the kidney. Here we see that palpation may be done in the upright position of the patient. Here we see palpation of the right kidney, and here we see palpation of the left kidney of our patient. And in normal, the kidneys are not palpable, of course, but you may palpate them in case if they are located lower than usual, or in case if they are enlarged, for example, in hydronephrosis or in case of polycystic disease of the kidneys. This data of history and physical examination may be very scarce, and some urinary tract disorders cause not much symptoms and signs. What can we do in this case? Of course, we use laboratory examination, and in the first place, it will be urinalysis. This is one of the most frequently ordered tests. And you may detect by urinalysis and measure such substances as protein, glucose, ketones, blood. You may also find, using microscope, the presence of red and white blood cells, crystals, and casts. When we collected urine specimens, we use different variants. Most often we used first morning portion of urine. Sometimes in acute situation we may use any random specimen. Then we can use so-called clean catch method, or midstream portion of urine is used. Then we may collect urine for 24 hours and then examine it. And also in some cases we can receive the specimens by catheter or even after puncture in the suprapubic area. So laboratory testing for routine urinalysis. So we speak about the first morning portion of urine. So first we check physical characteristics of the urine, and then we have a series of chemical tests, and at last we examine urine sediment by the microscope to see different cells and components. So first of all, it will be macroscopic urinalysis, and you can see different variants of urine color. Here is normal color of urine, maybe a bit pale, but here we see the examples of hematuria. So urine is red due to large amount of blood in it. Here we can see change of the color of the urine due to the dysfunction of the liver, and we can see that urine becomes dark in case of the high level of bilirubin or bile pigments in it. And here is normal urine for comparison. Next. Here we see this first part of the urinalysis and what should be in norm in the urinalysis. We see that in norm most of the compounds should be absent and protein should be not more than 0.033 grams per liter in the morning specimen. Oh wow. By microscopy, we can check the presence in urine red blood cells, white blood cells, epithelial cells, castes. And this is very important. This may be only in urine. Castes are proteinous or cell formations of tubular origin. So they may be developed only in the tubules, in the tubular urinaly, and they have cylindrical configuration and variable size, and they are the sign of the affection of the kidney especially. And then we can see also bacteria and different crystals. This is the example of the hyaline casts in the urine. They appear very pale and refractile, and they are common findings in the urine. Next picture shows us tubular cell cast. This all is cast, and it consists from the remains of tubular cells which are pasted together. And such picture, such finding is the sign of affection of tubular epithelium. One more cast with rectangular shape here, so-called granular casts. Yes? Well, here are the examples of the crystals in urine. This is oxalate crystals that look like small envelopes. Oxalate crystals may be common in urine, but in very small amount. Next variant is phosphate crystals, which look like rectangles. And this is second part of the normal urinalysis, and you can see that the amount of epithelial cells, leukocytes, erythrocytes, and casts in normal urine should be very small, and casts considered normal only for hyaline casts. All other are not normal, and a small amount of oxalate or phosphate and even very small amount of bacteria may be present in normal urine. Oh, well, we can also use Nephritic test for a count of erythrocytes and leukocytes in 1 milliliter of urine. For this test, you need clean cage or midstream sample. And here you see normal counts. So in norm it should be not more this amount of erythrocytes, leukocytes, and hyaline casts in the urine. If it is more, it is considered erythrocyte urea, leukocyte urea, and increased number of cast or cylinder urea. Next test, which is usually used to examine the function of the kidneys, is so-called the Miniski Test. For this test, the patient collects urine at 3-hour intervals, 8 portions during 24 hours, and the volume of each portion and specific gravity of the urine are determined. The volumes of daily and night urine are compared, and fluctuation of specific gravity during the course of the day. Here are normal values for the Miniski test. You see that ratio between daily and nocturnal diuresis should be 3:1. Well, and specific gravity should vary from 1.005 to 1.028, or at least differ not less than 10 points. Well, and the amount of urine during the day may be small, it is called oliguria, or high, it is called polyuria. Well, and you see that nocturnal diuresis, nocturia, prevails in renal insufficiency, and also for renal insufficiency is specific, that the specific gravity of the urine becomes permanent and low, and it is called hypostenuria. Oh, wow. To check the function of the kidney, we can also check in blood some substances. First of all, it is creatinine. Creatinine is increased in the blood when the kidney filtration rate is decreased by a large amount. We can also check for creatinine clearance, more accurate test, and then we can use specific formula that relates to the level of creatinine and person's age, weight, and sex, and we can estimate so-called glomerular filtration rate, GFR. And nowadays it is the best test to measure level of kidney function and determine the stage of the kidney disease. In healthy adults, GFR should be more than 90 milliliters per minute. Oh, well, besides functional tests, we can also use X-ray examination such as excretory urography or renal angiography, catheterization of the urinary bladder, cystoscopy, kidney biopsy, radioisotope nephrography, and echography or ultrasonography. All these instrumental methods may be used for diagnosis of different diseases of the kidneys. Here is the example of the normal ultrasound sagittal renal view. Look, we see the kidney, and we see parenchyma, which is more dark, and in the center we see calyces and tubular system of the kidney. Well, and here we can see a very large kidney which consists of a lot of cysts. This is the example of Politicistic kidney disease. And this is the same polycystic kidney disease, but as it is seen at computed tomography. On CT images, we can notice very large kidneys, which consist from a lot of cysts. Oh, wow. So here is the list of the main syndrome in nephrology. It may be renal edema, renal colic, nephrotic syndrome, nephritic syndrome, renal hypertension, renal failure, acute or chronic. And we see also the list of most common kidney diseases or abnormalities. They include glomerulonephritis or inflammation of the glomerula in the kidney, then pyelonephritis. This is also inflammation, but in tubular caste of the kidney. And then it may be hydronephrosis. It may be renal abscess, renal calculi, acute or chronic renal failure. So we begin from the diseases of glomerula, from different glomerulopathy, and they may be, of course, primary or secondary if associated with systemic disorders. And if they develop for the short time of period, it may be acute or rapidly progressive glomerulonephritis, or it may progress slowly as chronic glomerulonephritis. So what are the main characteristics of the glomerular disease? First of all, it is proteinuria. Proteinuria, the protein in urine. Especially, it may be due to nephrotic syndrome. We will speak about it later. It may be microhematuria or gross hematuria. And then it may be renal insufficiency, and it may be hypertension. What may be changes in the urinalysis in the case of glomerulonephritis? The main three signs of glomerulonephritis will be hematuria, presence of the red blood cells, then proteinuria, high level of protein in urine, and red blood cell casts. Do you remember? Casts are the sign of affection of the kidney. Oh, well. And one of the syndromes which may be present in glomerulonephritis is nephritic syndrome. In this case, in glomerular disease, there will be predominance of hematuria. It may be red blood cell casts and dysmorphic red blood cells in the urine, first of all. And then it may be proteinuria, which is non-nephrotic. It means that it is less than 3 grams per day. And it may be signs of renal insufficiency and hypertension. And of course, nephritic syndrome indicates the presence of glomerular inflammation or glomerular nephritis. Well, and here you can see the red blood cells in urine, but here you see that red blood cells are not changed, but here you see and here a lot of dysmorphic or destroyed red blood cells in urine. If you find this dysmorphic red blood cell, it is the sign of affection of the kidney, not ureter, not bladder, but kidney. If the red blood cells are not changed, in this case, we may speak only about affection of the lower part of the urinary system. And here we can see specific castes which consist from the remains of the red blood cells. Such red blood cell caste is the improvement of the glomerular injury. Oh, well, next syndrome that we need to speak about is called nephrotic syndrome. and it means in nephrotic syndromes the changes appear not only in urine but also in the blood and plasma of your patient. And the cause for this is heavy albumin urea. If the patient loses more than 3 grams of proteins during the day, so the changes appear in blood. And first of all, it will be decrease in the level of protein in blood, especially the decrease of the level of the albumins, because they have smaller weight and size and they are more easily lost in the kidneys. So their level may be less than 30 grams per liter in blood. Then also it will be increase in blood of the lipids. So total cholesterol may be more than 6.5 millimole per liter. This is specific for nephrotic syndrome. And as a result of the hyperalbuminemia, the edema on the different parts of the body may appear, first of all on the face, and then the whole body may be edematous. And also the high level of the lipids in blood leads to high level of them in urine also. Oh, well. And here we see a broad boxy cast which is specific for nephrotic syndrome. And also for such syndrome, it may be specific oval fat bodies that may be found during the microscopic examination of urine. And also to confirm our diagnosis of the glomerular nephritis, we can make the biopsy of the kidney. Histologic examination is obligatory now for the diagnosis of glomerular nephritis. And on this slide, we can see a lot of red blood cells and cast of red blood cells which form a group in the tubules, and also we see some foamy oval fat bodies also in on this section of the parenchyma of the kidney. Oh, well, the next pathology about which we will speak is called urinary tract infection. A lower urinary tract infection involves urethra, bladder, or prostate. But upper urinary tract infection, which involves kidneys, is called pyelonephritis, and it involves renal parenchyma. But pyelonephritis generally begins as a lower urinary tract infection, and then the infection goes up to the kidneys. What factors predispose to the development of UTI? You see that the male sex, some abnormalities anatomic, then kidney stones, and some instrumental examination of procedures in the urinary tract. Then you see the list of different organisms, microorganisms, which can cause the urinary tract infections. Here we see typical clinical presentation of the lower urinary tract infection. It may be dysuria, urinary urgency and frequency, hematuria, low back or suprapubic pain, and low-grade fever. Then we continue with the typical presentation of the pyelonephritis. In this case, the fever will be higher and patient may feel chills, malaise, nausea and vomiting, and it will be flank pain and tenderness. But of course, the main part of the diagnosis will be laboratory findings. First of all, we can reveal leukocytosis in blood analysis, incomplete blood count, especially with pyelonephritis. Then we can find out a lot of protein in urine. And urine sediment will contain white blood cells, bacteria, and white blood cell casts. They may be present only in pyelonephritis. So here we see white blood cells in urine, and if their amount is high, it will be the sign of inflammation and urinary tract infection. Also, we can see epithelial cells in urine, especially in affection of the lower part of the urinary system. And also, we can see specific white blood cell casts, which may be found especially in acute pyelonephritis. And the appearance of the casts in urine, high level of casts, is also the sign of pyelonephritis. We can also use urine culture to study which bacteria are present in urine. In this case, we use special examination, and we can see the urine culture here and here, yes, with a lot of the growth of a lot of bacteria. And here is a free zone due to antibiotics. You may check the sensitivity at once. And the next pathology that we will speak a bit is called Neurolithiasis. And if we want to put such diagnosis, we need to know about previous history of stones passage or history of stones seen by X-ray. It may be also a renal colic. Renal colic, this is specific syndrome which contains, first of all, severe pain caused by movement of a stone from renal pelvis into the ureter, which leads to ureteral spasm and possibly obstruction. So these signs, they are underlined here. The signs of nephrolithiasis in the urinalysis may be hematuria, pyuria, and pathologic crystals. And of course, your patient will complain about frequency and urgency of urination. Here is the picture of the cystine crystals shaped like a stop signs, and they are not common in normal urine but may be present in the case of the nephrolithiasis. And we need to say a few words about the term of chronic kidney disease. The chronic kidney disease is a disease or as a kidney damage or glomerular filtration rate less than 60 milliliters per minute for the 1.73 meters of the surface of the body, yeah? For more than 3 months. So some signs of kidney damage or diminished GFR for the period more than 3 months give you opportunity to put a diagnosis of CKD, chronic kidney disease. What do we mean as kidney damaged? It is defined as pathologic abnormalities or markers of kidney damage seen in blood, urine, or imaging studies. First of all, for stages of CKD, we use the level of glomerular filtration rate, GFR, and the albumin creatinine ratio in urine. The abbreviation is ACR. Here we can see the classification of the chronic kidney disease according to the kidney factor. infection stage. It is based on GFR. At the first stage, it may be what? It may be more than 90, the GFR is normal, but may be present in other signs of disease, such as changes in urine, in blood, or some findings on instrumental examination. And then we see that it is decreases consistently until the level of the 5th stage, when it is less than 15 and your patient needs a renal replacement or dialysis therapy. And here we can see the signs of the kidney damage, structural, and the range of this is based on the urine albumin to creatinine ratio. And here you see how the risk of the complications is increased according to the level of the structural and functional changes. This is all for today about the diseases of the urinary system. Thank you for your kind attention, and see you at I hope to see you at our next lecture.